Welcome to our umpteenth semi-annual statewide task force meeting. We are very happy to see such a good group turn out, and we have quite a few that have tuned in. I've got several emails from people who got planned to be in person, and then one or another thing came up, and they're still going to attend by virtual. We are very, very excited to have feature a committee each time we do one of these. We tried to pick one of our committees. We've done aging, we've done law enforcement, housing, and this one is care and resource. This is a fairly new committee. It was actually started after the pandemic at the request of the Attorney General to really talk about how we could make better connections with the community if, again, we had another situation like we did with the shutdown and the pandemic. But I think it's kind of grown beyond that original mission in some very exciting ways. And so some of you are here for maybe the first time, although most of you look very familiar. Some of them that are online may be new to this. I used to just advertise it to the AG task force, and then I started putting it out in my newsletter to the entire newsletter group, which is a couple thousand. And so we get some people that maybe not are familiar with it. So I'll just start with a brief history that when Mike DeWine was when he was Lieutenant Governor, and then when he was Senator, I worked with him quite a bit on criminal justice matters because he had been a former prosecutor, and I went to DC to testify on the Mentally Ill Offender Reentry Act, and he gave my Supreme Court committee at the time, my mental illness and criminal justice committee at the Supreme Court, the bill to look at, and we revised it substantially. It was supposed to be a bill to help courts, and it was rather anti-court written, and we changed it around a lot, and then we, on a next version of it, when it came up for reauthorization, added a real extra push for veterans in it. And so we had this long history, and then he became Attorney General, and he called me up and asked if I would consider forming a statewide committee with him focused on this sort of thing. And so I basically closed my court committee down that I had for, 10, 15 years, and then joined him, and we formed the AG task force. He was my co-chair, and Mike Sheeline was one of our directors at my staff connector, and Carolyn Bevins was there, and then Carrie Hertel joined us recently as my go-to people on his staff. And we did it for 8 years with Mike DeWine, and then Attorney General Yost approached me after he was elected to ask to continue it. And with now Governor DeWine's blessing, we continued it. It has now grown to 500 members. We've now are up to 15 committees. Each of them have co-chairs, so we have 30 co-chairs. And I recently met with one of the candidates for the Attorney General's office to prize them of the work, because I'm now being more aggressive about making sure this continues. And they asked me how we fund it. And I said, what do you mean, how do you fund it? They said, well, what's your funding source for the task force? And I said, we don't have one. I said, I'm a volunteer. My co-chairs are all volunteers or do it within their job. My members are volunteers. All we have is some staff help from Mike and Carrie and Carolyn. That's all? Well, that's just staff. I said, yeah. So I think there's might be some hope there for whoever wins that race to keep it going. The one who's running against him is actually a very close personal friend of mine from my old law firm, so I'm optimistic either way we will continue the race. So that's how it got started, and we have, like I said, 15 committees. So you're at this committee, but if you have an interest in aging, in juvenile, in law enforcement, in policy and research, in legislation, you name it, we probably have a committee for you. And if you'd like to join the task force, you're not a member yet, and you want to join 1, 2, or more committees, you're welcome to join as many as you want. Just let Carolyn know and let her know what committee you want to join, and she'll put you on the general list, and then she will also send your name to the co-chairs, who pretty much manage and run their own affairs. They set the meetings up. We generally meet quarterly, virtually. We did that before the pandemic because we didn't want people to have to travel. And so they meet quarterly, and the only restrictions are we ask that it be limited to criminal justice and mental illness. For example, we have a committee on veterans courts. Well, we could cover 20 different topics on veterans that are not criminal justice related, so we try to keep that focus, to keep the work really focused on and devote our energies to that issue. But we have every type of membership that you could possibly imagine. So we welcome you to join any of the 15 committees, or join this committee if you're not already a member. And we'll be looking at, along with Carrie and Michael, to see what committee to feature in the spring when we do our next statewide meeting. But it seems to work out well in the library, particularly since they have some good video participation and a screen in that. So this one is on integration, multi-system integration, which really is crucial to succeeding. If you can't do that, you really don't get anywhere. And one of the things I learned very, very early on when I was doing my Supreme Court Committee on Criminal Justice, I was meeting with some different state agency directors, and every one of them said, we need housing. And so we made a contract with the Supreme Court, and we got some of our partners to fund it that are my kitchen cabinet, my agency directors, to have Corporation for Supportive Housing to bring them into the meeting every time to teach the agency directors how to do supportive housing. And then I was on the National Board for Supportive Housing for 8 years. And recently when the task force was formed, the second year of the task force, Mike DeWine gave us $500,000 from a settlement to incentivize programs. So we had each committee make proposals, but we dumped a whole bunch of the money, $250,000, into a program that CSH and ODRC had started called Returning Home. And that is helping people who come out of prison then get housing, supportive housing, so that they can survive and not recidivate. Well, I just went last week to a showing of a documentary that CSH has done, actually a national group came in and did, on returning home. And they interviewed about 6 people on the documentary, and a couple of them were then live for audience participation. And it was just very affirming to hear about how these people came out of prison. These were long-termers. These were 20, 30-year people who had never, learned how to do anything that you think of as every day. Use a washing machine, use a cell phone, sign up for anything online. They had no skills in those areas, clothes on their back, no money. They got them in supportive housing. It's scattered housing. It's not in a group home. And they try to integrate them in the community. And many of you in this room have partnered with them to provide the supportive services. And it was just really life-affirming to hear how their lives had changed. They never ever thought they would have a house. They never ever thought they would not be back in jail or dead at this time in their life. The recidivism rates were dropped dramatically. They've shown that documentary now in several states, and I didn't realize this, but we are the only state that does returning home. And now 6 or 7 other states have contacted CSH and asked how they can start one of these in their state. So it's just, the work that we do has some ripple effects sometimes that you just can't imagine, and it's just so exciting and very affirming when you go to one of those and see the results of the work that we have done together. So it's very exciting. So anyhow, integration of services is key. You can't have one pillar, or the business case for housing shows you how important it is to have those supportive services. There's an infographic that I am very excited about that Sally Lucan put together when she did the business case. And a person from Delaware, a young kid, had cycled for 8 years through all the systems. He was like 400 or 500 days in jail, several 100 days in prison, almost 1,000 in hospitals, and she added up all the cost to the whole system. The rest, the court hearings, the different incarcerations, the hospital stays, etc., and cycle, no outcome, good outcome. They put him in supportive housing with robust services that now are just basic because he's stabilized. And in 4 years, he's not recidivated, he's not been rehospitalized, he's not been rearrested, he has a job. And she calculated over the 8 years, it costs the county for one person $644,000. If they had done that supportive housing with those services for those 8 years, it would have cost them $244,000. So they are spending about $400,000 with no good outcome. And when you show the business case to everybody, how these services that you all provide and integrate make a difference in stabilizing somebody, it really does. We can demonstrate mathematically that it saves money. There's another example in the infographics of a guy in Ross County that's still cycling. They haven't been able to stabilize him yet. It cost him $1 million so far in Ross County. Can you imagine the budget impact over the years that one person has had? So the work you do is so important, and the integration of the work you do is really vital. So I'm going to now turn it over to Dustin McKee. Dustin and I have had a long-standing relationship. He was on my committee way back as a NAMI representative. He was on my core team for stepping up, and then he ended up a couple different jobs, and now he's with the Ohio Psychological Association. And he has basically, as the chair, put this program together. We're going to have some great speakers. Thank you all so much for coming. Thank you, Dustin, and to our speakers for this opportunity to learn more about what we can do to integrate even further.
Thank you, Justice Stratton. We owe a great debt of gratitude to Justice Stratton for carrying on this work, and really a lot of the changes, well, most of them that I can think of over the last 15 years that I've been around in this system have been happening because of the groundswell of support from the grassroots networks that have been forming over those years, because the Stepping Up, State of Ohio's Stepping Up coalition across the states that Justice Stratton has led. And many of you, I think, have probably gotten involved in this work because of that. Well, and our presenters we will introduce shortly, but they have all been a part of the work of this committee before it was this committee. Way back when the pandemic hit, this committee was the pandemic ad hoc task force the Attorney General himself asked for specifically, and we met every couple of weeks, and we developed recommendations to quickly respond to what was happening, but also to prepare for the next pandemic, which unfortunately is somewhat inevitable. I think that the Resources and Care Connections Committee, it's gone through several different iterations in its name, so I get a little tripped up when I talk about it, was created to really have that multi-systems perspective. And these systems are so different from county to county, and they're siloed in various ways, as you have all experienced. I think one of the best things you could come away from today with is meeting a new person that is from a different county, in a different system, and figuring out what they do and making those connections. As was alluded to earlier, I came up in an MSW program, and systems are the thing for macro-level social workers, particularly when you're in the context of a rural area. You don't really have much choice but to sort of braid things together. And that's the sort of gusto that we brought to this work. So during the pandemic and afterwards, we looked at ways that we could stop the revolving door that we see between jail, homelessness, the psych hospitals, the emergency rooms, and things like that. And those systems obviously have a lot of challenges. We see, divergent medical record systems, something that, Rick Tully's here, he's been working on some of those things for a long time. When people leave the psychiatric hospitals, oftentimes the community mental health centers don't even know that they were in the hospital. Oftentimes when people are released from jail, it's at odd times of the day. These are systems that are really difficult to get your hands around. Sometimes the healthcare provider inside the jail doesn't have the behavioral health contract. Like I think here in Franklin County, Southeast has the behavioral health contract inside the jail, but there's another organization that does the healthcare contract. And that's partly why we have Laurel here today, who's previous job was with the Cuyahoga County Jail in the Metro Health System, which luckily was owned by the county. So we were able to have certain kinds of innovations as a result of that, and they had the EPICS medical record system. The introduction of Medicaid managed care, which doesn't seem like that long ago to me for behavioral health, but I think redesign got done, like 10 years ago now or something like that. When we carved in behavioral health into that, Medicaid managed care became a player, and Justice Stratton had been working for a long time for Medicaid not to be terminated while people were in jail. And so Medicaid is still suspended when people go into jail. So that means that those Medicaid managed care organizations that are paid upfront per person and incentivized, hopefully because of outcome measures and pay for quality, and because of that upfront payment method, they're incentivized to try and do some work ahead of time to predict and to prevent bad outcomes. But when somebody's in jail and they don't have a payer, they can't do some of that in reach. So we recently saw some things happen as a result of a lot of the work, again, quietly happening in the background because of you, because of Justice Stratton. We saw an 1115 waiver that was passed into the state of Ohio's budget. And so there's some green shoots all around. I think, with all of the different changes at the federal level and systems, I think people are worried that the work that we're going to do is going to get pared back and it's not going to be able to make progress. I just think that there's actually, the bigger picture is there's just different fronts. Luckily, we didn't see Medicaid turn into a block grant system, which, I mean, for those of you old enough to remember AFDC turning into TANF and being much less effective in that sense, at least in my opinion, we didn't want to see that happen with Medicaid. And so we're hoping that some of the exemptions for the work requirements won't lead to a lot of people dropping off the rolls and making it that much harder for us to coordinate care. So we have Dr. Sperber here today to talk some about how one of the largest Medicaid managed care organizations invested in some information infrastructure that they are able to see when, if this is CareSource, when their clients are actually in jail, when they're put in jail, when they're discharged, and then they can do certain kinds of follow-ups with that. They take all the publicly available information about jails and they can know when their clients are in there. And now that we have that 1115 waiver, if we're able to cover some of those folks that are in those jails, we might be able to not just do follow-up after discharge, but maybe even in reach while they're in there. We have Dan Mistak here, who has a broad perspective on national developments, and he shares my passion for federally qualified health centers. I work with, I'm on the board of the Primary One Health. If you've heard of Primary One Health here in Central Ohio, we have 40,000 patients. There's 40,000 people that call Primary One Health their medical home, and it's a federally qualified health center. And the reason that we see those FQHCs, as they're called, as a possible solution is because they have medical, dental, vision, mental health, substance use care, all under one roof or at least contracted. And so that makes it a little bit easier to get things across the board, like we've seen with Metro, although they're not an FQHC, they do have a look-alike. And so the idea here is to start giving folks more of a 360-degree perspective. These systems are obviously changing, but there's opportunities right in front of our eyes. Sometimes it reminds me of how I'll be looking for an item in my house and then it's just sort of hiding in plain sight right there. And that's what happens when you take that multi-system perspective. So thank you all for introducing yourselves. And I think what we'll do now is we'll move forward praying that the system works for us properly, and we'll introduce you to my good friend Dan Mistak. Please join me in welcoming him.
Thank you so much, Dustin, for putting this together, bringing everyone here, calling me down here. I really appreciate the chance to share with everyone. And Justice Stratton, thank you for the decades of service. I want to start by sharing that I met Justice Stratton a little over a decade ago. She was at some convening that was happening through the nonprofit that I work at, Coaches. And I told her, I said, Justice Stratton, I'm from Ohio originally. I really want to get back there someday. So like, if you can figure out how to get me back there, but regardless, mark my words, I'll be back someday. It took about 10 years, but finally I made it back. So I am Ohio native. I grew up in Trumbull County, out in the country, town of 800 people called Greene, Ohio. Sounds very bucolic, and it was. My dad was a steel worker. My mom worked at Burger King. It was very like Bruce Springsteen kind of childhood. As I graduated and went to college, that dragged me away, but I always loved Northeastern Ohio. And it wasn't until about 3 years ago that I had the chance to move back. I bought a farm in Ashtabula County, so I came here this morning passing Amish people as they were waking up and getting their day started. I did not realize that they started that early, but they're up and at work. And I'm just grateful for the chance to be back here and to all of the stories that I have that have motivated my work are from people in Ohio. And so I have been grateful to carry my aunt who lived with schizophrenia, who the first responders when she was having a crisis was the county sheriffs in Trumbull County, or my cousin's husband who suffers from or lives with polysubstance use disease and has had to figure out where and how he could fit into the recovery system when he went from using 2 substances to then using 1, but then being taken to jail and then wanting to come back into his program before, but since he was only testing positive for 1 substance, he couldn't even access that program anymore. So I started seeing how these different systems are not supporting the people who have some pretty critical needs and frankly have a lot higher burden of paperwork and bureaucracy than I do. And I struggle with paperwork and bureaucracy. I mean, it's one of my least favorite things to do is see the pile that I've been ignoring and saying I'll handle that someday. That doesn't disrupt my life by putting that off and then doing it later. But for him, and for not just him, for my cousin and for their 3 kids, those sorts of things ended up making it so that he couldn't get a job, so that he wasn't able to get connected to care, and had major consequences for his family. And so all of these stories were the things that I've carried all over the country. Coaches, the nonprofit I work at, is a national nonprofit. And so I have carried Ohio with me everywhere. And I am incredibly grateful to be back here, to have my little 10 acres and my geese and my ducks, and 10 baby ducks right now, which is very exciting. But to be able to be here and be doing this work too. So I'm just grateful for all of you for being here. So what is Coaches? Coaches is a national nonprofit. We were started in 2005 with a grant from the Robert Wood Johnson Foundation. So Robert Wood Johnson Foundation is just one of these big healthcare foundations. And the goal was to try and create a system of care for people who are moving from jails into the community. How do we make this work better? And the initial goal was to say, well, why don't we leverage our federally qualified healthcare system, federally qualified health centers, in order to try and make that connection? Well, immediately bumped into some major policy barriers, some statutory barriers, some regulatory barriers that made that nearly impossible. But we've continued from then to say, okay, given the world as it is, how do we try and make these connections happen? So what we've done in that process is we've provided technical assistance to local counties, to states, even to federal agencies as they're trying to think about what does it actually look like on the ground as we're the federal agency trying to make policy without ever being inside of a jail. And so we have worked on every single one of the issues that I'm going to cover today because somehow we've had success with the things that have happened. And it's not just us, but it's the fact that we are able to translate and to bring together a coalition of people who are working for the people who are incarcerated, for the people who are working in the facilities, for the people in the community who want to serve the people in the facilities, but they can't reach them. And we've convened folks in order to actually be able to speak the same language and to drive some change that is hopefully going to continue to have impacts on people who are critically at need. So what is Coach's goal? We want to take this person here who's in the middle of our healthcare system and to be able to make sure that wherever they receive care, that it is high quality, that it's transparent, that it's connected to wherever people need care. But as it exists right now, for the most part, this person, if they're getting care in any one of these other, in most of these settings here, they're all connected. But if that individual receives care inside of the jail, that's cut off from the rest of the community. He said even just transferring data ends up becoming a challenge. So for health nerds, this ends up being a major problem, right? Because the North Star of what we're trying to go towards in healthcare is we want integrated care, we want high quality care, we want to be able to lower costs by making sure that we're not redoubling our efforts over and over again. So having the jail as a major healthcare provider, particularly with people with some pretty high needs, substance use, mental health conditions, maybe you've never seen a doctor in the community before, well, that's an expensive place to be providing care. And it's certainly expensive to provide it there and then not share that information with anybody in the community. So what we try and do is to incorporate the jail inside of our broader healthcare system. And yeah, I can, yeah, you're relieved. And so that's like the health nerd policy frame for it. But the truth is that people who are entering and exiting our jails are just temporarily displaced members of our community. COVID really fundamentally changed the way people think of jails. Many times they're like, okay, we're getting rid of the things we don't want to see. Just get it out of our sight. Well, COVID woke people up to the fact that, well, people will go into jails with health conditions. They come out of jails with health conditions. And so that really made us many people start thinking about what happens inside a jail in a different way, which has meant that we've been able to have these gains that we're going to be talking about. And underlying all of this too is that there are significant racial disparities in both our health system and our justice systems. And by trying to leverage the strengths of our health system, another North Star that we have, it's all in the same direction, it's all still heading north, is that we can reduce the racial disparities that exist inside of both systems as well. Because it probably doesn't surprise anyone inside of this room, but people who are incarcerated more often tend to be poor, tend to be people of color, tend to be people who are already marginalized, people with serious mental illness, people with substance use disorders. So if we can reduce the disparities inside of our health system, use those strengths, we can reduce the disparities inside of our justice systems as well. So I'm here to paint the big picture of what's happening on the federal level. These are things that I've had the pleasure of working on over the last decade and was told would never happen in my lifetime. And I believed it for a little bit, so much so that I left coaches for a while and went to go and start a medical legal partnership on the big island of Hawaii. I was living on a coffee and macadamia nut farm. And then when the pandemic hit, right before then, was called back to coaches in order to try and see some of these things over the finish line. And then at that moment, I was like, well, I've got to get closer to DC. Well, why don't I just make this Ohio thing happen that I wanted for so long? So that's how I got back to Ohio. But you heard Dustin say 1115 waiver. How many of you have heard of that before? All right, good. That's more people than I expected. So these 11, that's great. A good place to start.
There are people.
That's right, good. So why, before I get into what the 1115 waiver is, why would something like that be necessary? And that's because the Social Security Act, which is what has defined all of the rules for how Medicaid is supposed to operate, it excludes certain people from being able to receive services, even though they may be Medicaid eligible. Those two groups, for the most part, are people who are in institutions of mental disease. So those would be like rehab facilities, residential facilities, but also people who are called, quote, statutory language here, inmates of a public institution. So this is the reason why Justice Stratton has been fighting to suspend rather than terminate Medicaid, is because the moment you're booked into a jail or anything that's deemed to be a public institution, you lose access to Medicaid. Regardless of whether or not you are eligible and you meet all the criteria for eligibility, you're done. And what that's meant is when you're released on the other side, in jurisdictions that have not done a good job of this, it means you've got to reapply for Medicaid. Once you reapply for Medicaid, you better pray that your pharmacy benefit turns on in time for you to go and pick up your prescription. And if not, you're just going to be back in the churn of not having access to medication. That lack of access could lead to operating within the justice system again. And so one of the goals that I had at Coaches was to say, well, during the Obama administration, we allowed for an 1115 waiver to waive the institutions of mental disease exception. So why aren't we waiving the inmates of a public institution exclusion as well? Why can't we ask, as a state, the federal government to say, hey, we want to try and connect people with care before they're released and try and make that care not cost more expensive than it would be normal. This is how 1115 waivers have to, of course, always be structured. They have to be cost neutral. And so what this is the chance for states to request from the federal government to waive that inmate exclusion for a certain period of time. The federal government released guidance on what these waivers could look like. So it's up to 90 days before release from a jail, prison, juvenile justice facility, anything that's considered a public institution. It has to at least cover case management, medications for opioid use disorder, and also 30 days of case management upon release, along with bridge medication, 30 days of bridge medication upon release. So the state has the option to request this, and a state has the flexibility to request the entire set of benefits that comes from the Medicaid program. It's really up to states to decide that. They could also decide we want to do prisons instead of jails, or we just want to do jails, which would be really interesting if they try to do it that way. So there's a lot of flexibility that the state has to define a waiver that works for them. And I'm happy to report that the state is going to take a bite at that apple. So inside the budget that was just passed, the state has 1 year to apply for one of these Medicaid 1115 waivers that's going to allow for Medicaid services to be started in the jail up to 90 days before release, into jail and prison. I should say coaches focuses mainly on jails because, you know, as you know, jails and prisons are very different things. A lot of people focus on prisons because you know when someone's going to get out. It's a little bit easier population. It's you know what's going on with them. Jails are like crisis mode all the time. People are in there for shorter than 2 weeks for the most part, shorter than 30 days for sure. And so jails end up having more bang for your buck if we could figure out how we weave that into our broader health system, and that ends up being a place where people can maintain their care when they're incarcerated to when they're released. And so that's why I might be slipping into saying jails a lot when I really mean the entire correctional system. So the Ohio budget is going to require the state to apply for one of these waivers. And I just want to flag that because this is a massive opportunity. We don't know what the state's going to put inside of that waiver yet, but the state has a lot of flexibility about what's going to be in that waiver. Some states will do the bare minimum. The 3 required things that I mentioned earlier, we'll shoot for that. This is, you're now the vanguard here of saying, well, we could make this actually as broad as we want. We can try and expand this. And also the benefit is 90% of it's going to be paid by the federal government because Medicaid is a state-federal partnership. And so when this is expansion population, sorry if this is getting too nerdy about things, but these are people who are mostly, the costs of their care are mostly borne by the federal government. So if we can import that into the jail, that ends up being a considerable cost savings for the local jurisdiction or the state, depending on.
Dan, do you know how many other states have applied
Yeah.
or are planning to apply?
Well, I don't know the exact number. It's around half, right? So I'm not exactly sure of what the exact number is right now. And if I were, in a Zoom call, I would have pulled up a map real quick and then, okay, I know. But there is, it's almost half of them. There are, I believe, 18 that have already had it approved. There are the remainder are still waiting for their approval. And they're all, the ones who have been approved are all in the process of implementation right now. So this waiver possibility was just a reality in 2023. That was the first waiver that was approved, was California's. Then it was followed by Washington, Montana, Kentucky, really red, blue, purple, all of the states are applying for these sorts of things.
Well, it was a big surprise, I think, to many of us that got tacked on towards the end of the state budget.
Yeah, you don't have to. Yeah, I'm with you 100%. Yeah, so it is a really exciting opportunity here. But just because something's passed inside of the legislation doesn't necessarily mean the executive branch is going to pick up the ball and run with it. So this is you've got some good grist for the mill of trying to make sure that the state is doing this already. So that's the federal regulatory changes, along with the supports of the state budget process that is supporting this 1115 waiver. But I also want to note that there's been a statutory change. So this is not just something that you have to jump through the regulatory hoops. There is a very real and living statutory change that makes Medicaid actually available for certain populations 30 days before release from jails, prisons, anything that's a public institution. What's that?
That's federal.
And that's a federal statutory change. So Section 5121 and Sections 5122 of the Consolidated Appropriations Act of 2023 modified that inmate exclusion component, but it modified it for Medicaid-eligible juveniles. So Medicaid-eligible juveniles, that means up to the age of 21, or if they're aged out foster youth, up to the age of 24. So if you are a Medicaid-eligible juvenile and you are incarcerated in a jail, a prison, a juvenile justice facility, so you are in those age categories, and we know that a lot of people in jail are up to the age of 21. We know a lot of people who age out of foster care enter and exit the justice system often again. You are entitled to 30 days of the screening and diagnosis benefit, of the EPSDT benefit, and my other lawyer friends who litigate this stuff tell me what that means is that's the full set of benefits for a Medicaid-eligible juvenile, 30 days before release, and also 30 days of case management before and after release. That's a federal statute. Some might call it an unfunded mandate. That's it's not exactly correct. The implementation of it hasn't really been funded, but now there is, because these are Medicaid beneficiaries, these are dollars that flow through the Medicaid program, and it's a question of how are we going to maximize it inside of the state right now, which remains an open question. So 5121, that is the law of the land. That it went live January 1st, 2025. How many of you knew about that going live? All right, 2 people here. Awesome, good. I like that. I like to share new things. The state also has an option under Section 5122 to request, just through a very easy process, a SPA process, to request that the entire set of Medicaid benefits for Medicaid eligible juveniles be maintained the entire time the Medicaid eligible juvenile is pre-trial. So that is the entire time someone's waiting for their trial to happen, they can go through this process of having their Medicaid benefits turned on, which means better coordinated care, connections with community systems. But the challenge is that there are challenges in implementation. I'm sure many of you are already thinking about it right now. You have to identify who's the ones that this actually works for, how many, if 5121, how many days are they before release? These sorts of things, the slicing and dicing of the population makes implementation a challenge, and I don't want to pretend like it's not. So those are 2 major statutory and regulatory changes. You have a question? Yes.
I have a question.
Yeah.
With the bridge medications, we hear a lot with the jail staff around how challenging it is to get individuals with SPMI injectables. And so will this waiver have any focus on injectables, particularly when people are coming out, because that is always very, very challenging to get them reconnected to post.
Great question. Yeah. So what I would say is, one thing, first of all, is the waiver hasn't been written. So there is so much opportunity for advocacy and exactly that concern to be elevated to ODM. I think they'd be really interested here. But what I would also say is it's going to depend on what's covered by the Medicaid plan in the state. Right? So if the state Medicaid plan covers injectables, then that's something that I would be able to say, yeah, sure, then that's something that ought to be covered inside of the waiver. If that's something that's not covered by the state Medicaid plan right now, then I think there'd be some needs to make sure that gets covered inside of the formulary, and then that ends up becoming that opportunity through that. So really, there's going to be a major need for kind of cross collaboration across the justice silos and the Medicaid silos. And let me tell you, the Medicaid folks are happy to forge ahead without collaborating. I mean, I've seen it in many, many states. I even had somebody in California who told me, they were, Manat, one of these giant law firms, it's billing $500+ an hour for this. And I said, well, what are you doing? Are you reaching out to sheriffs? How are you thinking about implementation? They said, oh, no. We'll write it and they'll have to do it. So which is just like, very clearly no one's ever met a sheriff or a sheriff's deputy in their entire life, because that sort of thing is, a request for rebellion. So what I would say is, make sure that you're a part of these conversations, because it's very easy to just be kept out. And then suddenly they're going to be scrambling of, oh, we've got to implement this waiver. And now it's time to actually find out what's the difference between a jail and a prison. So, let's hopefully avoid that fate that I've seen many states wander into. So these laws impact kind of the financing side of things, but there remains a major question of who's going to be the provider, right? There's so many companies that want to contract with your county in order to serve your population. And then there's also, a variety of like public hospitals or FQHCs who might be interested in this. So I wanted to make sure that we were all on the same page of what is a federally qualified health center before I talked about this new opportunity with FQHCs. So FQHCs were created by the federal government as a new provider type. They are community-based health centers. They have a few unique features that make them different from a lot of other healthcare providers. Their goal is to provide comprehensive primary care. And that can include behavioral health services, dental care. Those require expansion, and the FQHC decide to take on those. But they're very, very broad in what they can offer. And the goal of them is to serve medically underserved communities or populations. So there are FQHCs that are serving migrant workers or unhoused populations under different statutory authorities, still inside of the FQHC universe, or they focus on medically underserved areas or medically underserved populations. For those of you who might be from a rural county, this might start setting off alarm bells, because FQHCs exist in a lot of rural areas. And also at the same time, getting correctional health care is a major challenge in many rural counties at the same time. So if we could figure out how to merge these two things together, the need inside of correctional facilities and also the fact that there are FQHCs already serving communities, we might be able to be on good footing for trying to figure out one of the major challenges for local communities. FQHCs are required to provide care regardless of the ability to pay, and they're governed by a consumer board of at least 50% consumers of the services by the FQHC, which is a major really impacts how services are directed and thought of by the FQHC. Now, the really cool thing about FQHCs is that they receive an enhanced Medicaid reimbursement. They don't have to go through the annoying, I mean, they do, but it's a different, it's a little different. They're not necessarily billing a Medicaid managed care plan. Every state kind of slices and dices this differently. And they may have to build the plan and they get a certain amount. But the thing is that they're entitled to, FQHCs are entitled to an enhanced reimbursement rate that's called a PPS rate. What that is they take the entire amount of services that are offered that are in scope services, they divide that by the total number of encounters, and they get one, and there can be more. So I just want to caveat for the other health nerds in the room, but you get essentially one PPS rate. So that if I'm seeing patient A, I'm going to get the exact same PPS rate if I'm seeing patient B, and it doesn't matter what patient A's needs are versus patient B's rates are, or needs are, I draw down that same rate no matter what. And it's higher than what happens through a Medicaid bill. The point of this was to try and say, how do we make sure that these clinics can stay alive, because Medicaid is incapable of meeting the actual costs of the services that are provided. So FQHCs get this special boost. They also get a few other benefits too. They get 340B pricing, which is a discount pharmacy benefit program as well. There's other entities that can get this as well, but FQHCs can get that discount pharmacy rate, which, for anyone running a jail, that's like alarm bells are going off, because that'd be real nice to get some of those discounts. And then on top of that, FQHCs also get protection under the Federal Tort Claims Act. So that means that if the FQHC is doing all the things that they're supposed to inside of the scope, and they're following the rules that they're supposed to, if there's a claim that comes against them, instead of them having to lawyer up and them having to have their own insurance, the Federal Tort Claims Act actually protects them, and the Department of Justice steps in to defend those claims. So, as many of you are probably thinking, it's incredibly expensive to provide health care and also face possible lawsuits for the care that's provided. If one could have the federal government stepping in to protect one, that's a huge liability. That's a huge cost that's off the shoulders of an FQHC. So FQHCs would be an amazing partner in order to have inside of the jails. And let me remind you, this is in 2005 what COACH's original goal was. But after COACH's, my nonprofit, worked to bring in our FQHC inside of a jail in Washington, D.C., the federal government said, no, we're not going to do that anymore. We don't want to step in for any of these sorts of things. We don't want that extra cost, et cetera, et cetera. Well, at the 11th hour of the Biden administration last year, the day after Thanksgiving, BIPIC, which is the agency that oversees the Federally Qualified Health Centers, released new policy guidance that will allow for FQHCs to offer in-scope services, which means all the benefits, PPS, FTCA coverage, 340B pricing, allow them to offer in-scope services 90 days before release from a correctional facility. So that is a massive, massive change that nobody yet is able to still figure out how to put into practice. I mean, there's been a lot of bumps that have happened inside of the health system in the last few months. So this is something very live, very new, and should be of interest probably to a lot of folks inside of this room. So this new opportunity comes out of the PIN Policy Information Notice 2004, number 5, and it would allow for health centers to provide services to justice-involved individuals within 90 days of release from prison or pretrial detention. There's a few caveats on this, right, that I think might make it challenging for thinking about partnerships with jails and prisons. So the services have to fit inside of the HRSA approved scope, so they have to get federal approval for a scope change, is what it's called for the FQHC. And the agreements with the carceral authority, whether that be a jail, prison, juvenile justice facility, has to maintain the autonomy of an FQHC. Right? I know in corrections too, the idea of anything else maintaining autonomy inside of the facility might be a challenge to imagine. But if you can figure out this relationship between the jail and the FQHC, there's a lot of benefits on the other side, because the service range is absolutely massive for what an FQHC can offer. I just copied some of them there: care coordination, health evaluations, communicable disease screen, primary care, which is very broad, behavioral health, MAT, reentry support. These sorts of things could be handled by an FQHC. That FQHC has a financial interest in participating because they are receiving an enhanced reimbursement rate. They have protections from the Federal Tort Claims Act, and these are the same people that they're going to be seeing in the community. So they want to maintain that continuity of care both inside and out. So this new opportunity from the FQHC, there are some things that have to be realized before that can happen. First of all, I want to say that under the 5121, that statutory change that's already happened, that population, you could target them right away because it modified the inmate exclusion. It allows Medicaid to pay for the services offered there. It will take time. We will need that Medicaid 1115 waiver in place if we're going to then fully maximize this, because that waiver will waive the inmate exclusion for the entire population that's covered by that, by the waiver, which means more opportunities for that FQHC to offer the full set of services. But again, this requires aligning what the waiver actually says with what the facilities are that are going to use this, and then also getting on board the FQHC organizations here inside of the state too, the primary care associations, in order to get them to support this as well. So there are the regulatory statutory things, get that 1115 waiver, we can maximize this. But then there's a lot of coalition building that I think has to happen before we're able to actually see this realized. But there is something massive and important. Yes, sir.
Can you talk a little bit more about retaining the health center's autonomy?
Yeah.
What does that mean?
Well, I mean, we don't know yet, right? So the language that it says inside of the PIN is that the FQHC has to carry out its duties on behalf of its board, its governing board, which is 50% consumers. So it's supposed to just be carrying out its responsibilities. You can lay out those responsibilities in an MOU, right? But it's not supposed to be acting on behalf of the carceral facility. So it isn't supposed to be saying, I'm doing this for you. The sheriff says, go and give that person, thimerosal or whatever, and then you go, okay, yes, sir, whatever you say. It's not supposed to happen that way, right? The FQHC has its policies and procedures. There's an MOU that's worked out with the facility, and the FQHC is not answering to the sheriff or to whoever, the warden, whoever's overseeing that. So there does require a lot of respect, a lot of understanding between these groups in order to make that happen. To throw one more little thing out there, a little wrench, is that FQHCs, lookalikes, want to toss this out because many counties take advantage of this opportunity too by creating something called an FQHC lookalike. So this is an FQHC in almost every regard, except it is not an FQHC. It's a lookalike. But that does mean that that lookalike gets PPS coverage, it gets the 340B pricing, but the thing it doesn't get is the Federal Tort Claims Act protection. So many counties create a lookalike. So Metro Health up in Cuyahoga County, which is a publicly run hospital, they have an FQHC lookalike as well. So many counties operate these in order to maximize revenue or to fill holes inside of their facility. But just want to say that many counties may be thinking about how they're may already have a lookalike, which makes it a lot easier to kind of think about what these relationships could look like. And so just want to toss that out there that there may be a lot of low-hanging fruit because counties are already trying to take advantage of the FQHC lookalike opportunity that exists. So we would be remiss if we did not talk about the one big beautiful bill, which, frankly, as a healthcare nerd, it's someone who cares about people who lack access to our systems. This is going to be a disaster for our healthcare system. And that includes me too, right? Because I also buy my healthcare, and healthcare is actually a very communal thing. I'm paying my premium every month to cover my neighbor if they need it, if I don't. So if suddenly people are getting pulled off the off the rolls, or if healthcare costs go up and fewer people are buying insurance, if I'm still buying insurance like a sucker, that's going to cost me a heck of a lot more money. So, these are some of the dangers that are coming because of the One Big Beautiful Bill. But silver lining is that the community engagement part, which is the work requirements, which is really a paperwork requirement. It's not actually a work requirement, because if you look at the data from states that have tried to implement this, the people who are working still lose access to their care, not because they're not working, but because their paperwork didn't process or there was some challenge along the way. By the way, there's no funding federally for trying to make these work requirement paperwork things happen. So it's going to be quite interesting to see what implementation looks like. But these community engagement requirements made me nervous about what was going to happen with these 1115s or with this 5121 stuff. And happy to report that inside of the legislation, people who are incarcerated are carved out from needing to meet the requirements of the work requirements, and they're also protected for 90 days after release. So at 90 days after release, they've got to be meeting all these work requirements. But while they're incarcerated, they still maintain their access to Medicaid coverage. And then 90 days after release, they still maintain their access to coverage. And there are quite a few other carve-outs too. People with SMI, people who are in the midst of a recovery program. So it's a real great opportunity for people who are ending up inside of the justice system to help identify, to do case finding, to see, do they fit inside of any of these other carve-outs? How can we connect them with the necessary paperwork to make sure that they can not have to meet the onerous components of the paperwork requirement too? So there's a real opportunity here because this population has sort of been protected. It also means that the 1115 waivers are still going to remain important. They're still totally actionable. 5121 still is going to be the law of the land. 5122, should the state care to do that, is still going to be a real opportunity. And I also will say that the 1115 waivers almost have a bigger imperative now at this point, because one of the things that the 1115 waiver does is it says that every state dollar or local dollar that's offset by a federal dollar, remember 90% of the care costs now is covered for Medicaid is covered by the federal government. So anything that's offset by the federal government picking up that 90% has to be reinvested back into the community. So those dollars then can be shifted. If we're spending, say $1,000 on an individual while they're incarcerated, we would love if it were that low, right? So let's say $900 of that ends up being covered by the federal government. Well, that $900, instead of it just going back into a general fund, is supposed to be reinvested back in the community. And as we're facing a time when I think we're going to be seeing a lot of challenges and a lot of programs and a lot of tough decisions being made, this, in my opinion, becomes such a no-brainer, because we say we can offset the cost of what we're doing, bring in higher quality providers, we can have the federal government foot the bill for 90% of that, and then we can take that 90% and reinvest it in some of the programs that were being cut. So this is a real opportunity. There's a real good argument for this, and I just wanted to make sure that I threw that out there. So this is kind of covering everything that we've talked about here today. So before the Affordable Care Act happened, most people just did not, who were entering and leaving the justice system, did not have access to health insurance. Once the Affordable Care Act passed, the vast majority of the people who were entering and exiting the jails had access, were eligible for Medicaid for the first time, but that inmate of a public institution exclusion was really limiting our ability to maximize that and to make sure that they have high quality care inside and out. Since then, since 2020, we've had these huge gains when it comes to the regulatory, the 1115 stuff, and also the statutory changes that have happened, the 5121 stuff, to actually bring Medicaid financing and providers inside of carceral facilities. And now we've got this, lightning bolt that is hitting where we are, that may have disrupted what the new opportunity is a little bit, but it's not completely destroyed. Because this is a chance now to really strengthen all of the things that we've talked about. The access to care while people are incarcerated, their ability to connect with things in the community, their ability to maintain their Medicaid status even as they're as they now find themselves in one of these other carved out groups in order to maintain Medicaid. So I think that we would be remiss not to see this as a massive opportunity in the face of all of this, that although the clouds seem dark, there are some really bright silver linings. And thank goodness to the State General Assembly for passing this 1115 requirement inside of their budget So I just see a lot of opportunities ahead for Ohio, like perfect timing right now for all of this. And I'm really excited to hand this over to the other presenters who are already talking about some of the groundwork that's been laid that I think will make it a huge opportunity to maximize what's going on here. So here's my contact info. Of course, leaving at 4:30 this morning, I did not grab my cards. So take a picture of this or shoot me a text or something. And happy to connect with all of you. And thank you all for being here and for all the hard work that you've done to get this stuff started. And I'm just grateful for all of you to be part of this. Thanks.
Well, you didn't think that you'd hear about silver linings today, since there's been a lot of disruptive events, and I think that there's a certain general pessimism that cut through, Dan. So thank you very much. I didn't realize the extent to which we might have some opportunities to push this work forward, not just maintain it, but actually make more progress. So that's one of the advantages to making sure that we take that 360-degree view. That multi-system perspective is so vital. So I'm going to introduce our next speaker, Dr. Kimberly Sperber. I didn't realize until I started working with her several years in that she really is known nationally as one of the leading researchers in this very sort of niche area of working with folks in jails with serious mental illness and substance use disorders, and how we can do in-reach and how we can coordinate care. And she really helped to mastermind the study that CareSource is doing. She was employed at both CareSource and Talbert House down in Cincinnati. So please join me in welcoming Dr. Kimberly Sperber.
So I'm Kim Sperber. I am here today from Talbert House. I am the director of the Center for Health and Human Services Research. I started in Talbert House back in '97. I was placed there as a doctoral student for my graduate assistantship. So my standing joke is that it was supposed to be temporary. And it's 2025. So I didn't think I'd commute to Cincinnati from Dayton for 30 plus years, but here we are. And that speaks to the work that we do at Talbert House. It also speaks to an agency that's always been very open to data and research. And every time I've had an idea, they said yes, which is how I'm still there. So, we are unique that we do operate a research center within a practice agency. In 2019, I branched off and went over to do some work at CareSource. Again, the plan was to I did that in February of 2019. The plan was to leave Talbert House by the end of that calendar year. I never did, so I bridged both of those jobs for 6 years. Again, I think speaks to the draw of the work at Talbert House, and I am now back there full time. But while I was with CareSource, had the opportunity to participate as a co-investigator on a really novel and first of its kind study funded by the National Institute of Mental Health. And so I'm here to talk a little bit about that work and sort of the uniqueness of that and how it plays out in Ohio. But before I do that, I just want to set the stage a little bit. I think we all know the number of folks who are under correctional supervision, but I think we always kind of set the stage by looking at those numbers because they're fairly large for our country. So if we look at 2022 data, we had almost 5.5 million people under some form of correctional supervision. 2/3 of those folks tend to be in the community at any given time. And the reason I think that's important is while the study that I'm going to focus on for CareSource was also dealing with people in jail, the risk for suicide, when we talk about it, even in the literature, but even in the community, oftentimes we're talking about the increased risk related to incarceration. We're not talking about the risk that follows people out into the community once they leave incarceration, because their risk for suicide remains quite elevated for quite a period of time. And so that'll become important as we continue to move through the presentation. So if we look at just sort of some basic percentages in the prevalence of suicide within incarceration settings, both jails and prisons have a higher percentage of suicide deaths than the general community, but it is much more elevated within the jails. Some of that likely has to do simply with volume. As we heard, people are moving in and out at high levels, and they're moving in and out very quickly. Suicides, whether it's jails or prisons, are more likely to happen in larger facilities. There are just different stressors involved with large facilities. Inmates who have not yet been convicted account for almost 80% of suicide deaths that occur within jails, which does make sense. If you look at the fact that at any given time, 65% or more of individuals who are in jail are pre-conviction. So it makes sense that that population is overrepresented among suicide deaths. There is a trend difference in terms of when they occur between prisons and jails. So suicides within jails are much more likely to happen very early on relative to jails. And so that becomes important when we start to look at identifying people at risk, doing assessments, getting them triaged and getting them into care, which is also then compounded by the fact, as we talked about, with the churn and the volume, which is why jails tend to struggle with doing that at a high level. Even though we have seen some jails, and we'll hear about some of that potentially today, that have done a really good job with that, it is still a challenge in that environment. So again, just sort of setting the stage before we start to talk about these things. And so when we look at the risk factors for people that are involved in the justice system, much of it looks very similar to the general population, but we do see some differences. One is actually prior multiple arrests. And this became really important in our work because it's not clear that at the provider level, like the outpatient community providers, that arrest is actually being actively integrated as a risk factor when making decisions about who should be screened for suicide risk. So having been released from jail is actually a risk factor, having been released from prison. Alcohol abuse and illicit drug use are associated with obviously increased risk both in the community and within incarceration settings. Research has also shown that substance use disorder can successfully identify or differentiate people who have ideation versus those who complete. And so successfully treating substance use disorder in and of itself is a preventative mechanism for suicide risk. We see a very high burden from what we call medical complexity and chronic conditions in this population. So actually the work I did at CareSource while I was there was actually within their complex health solutions division. And I was there to specifically help work with the interventions they wanted to create for people involved in the justice system, because there's a substantial proportion that have medical complexity, meaning a certain number of these folks have a substance use disorder, they also have a severe and persistent mental illness, and they also have at least one major chronic care condition, with many of them having more than one major chronic care condition. And if you look at most of the major health crises in our country, they converge on people involved in the criminal justice system. So they often have multiples of these, which makes their care very complex. And so that burden adds to suicide risk. The co-occurring disorders also, as we all know, is a risk factor, and so is service fragmentation. And we do know there's often poor care continuity, and that's actually how CareSource got involved in the work of dealing with trying to figure out when their members were going in and out of jails, because we know we lose people to treatment. So even if they were engaged in treatment prior to incarceration, we often lose them during that incarceration period, even if they're only in there for a short period of time. And part of that's because they simply don't come back to care. The other part is the providers aren't aware that they've been incarcerated, not in real time. And so, again, I've worked on both sides of that fence, and so as a Tower House person, I'm very well familiar with how we lose folks to care. We don't find out. Sometimes we don't find out at all. If we do find out, it's well after the fact. And so it's harder to navigate that and keep people engaged in care when we don't know in real time. We also sometimes prematurely close out their record because we think they've just stopped showing up, and the reality is they're incarcerated. And if it's jail incarceration, oftentimes they will be back out in time that they could come back to care with us if we knew not to close their case and knew to do either in-reach or outreach upon release. So when we look at the risk points for individuals at risk, there's risk both within the system clearly. So there are things that happen within incarceration, and as you can think about, put your self in place and think about what it would be like to live in an incarceration environment. So you've got lack of privacy in those settings. You've got lack of meaningful activity. Sometimes there could be lots of downtime. There can be violence and victimization that occurs within facilities, and just insecurity about your future after release. We do hear reports of hopelessness while people are incarcerated. All of those things are risk factors for suicide. But as we mentioned before, that also follows out into the community, so that risk doesn't diminish. So if they continue to have persistent lack of social support upon release, if they're dealing with economic stressors, lack of employment, sometimes there's family strain, lack of housing, and again, fragmented healthcare, all of those things still contribute to the risk for someone upon release for suicide. And so when we look at reentry, we should be treating reentry as a high-risk transition. I've been saying this actually since the opioid epidemic, and that was related to overdose. But it's also true related to suicide risk. So no different than I think people that work in mental health understand that when people are released from a psychiatric hospitalization, we understand that first week to 10 days is a very high-risk transition, right? Release from prisons and jails and other correctional facilities is also a very high-risk transition. And so as a system, we should be working together to systematically address that transition for folks. So we know that the risk of suicide post-release remains high. the risk for all-cause mortality is high. You know, at least one study showing it's 12.7 times higher, so that if I'm released from prison or jail, I am 12.7 times more likely to die than someone in the general population, and that's from any cause of death. But the primary causes tend to be things like overdose, suicide, and some form of harm like homicide. One study showing suicide rates are 14 times higher for people coming out of prison than the general population. So it is clearly a risk factor that needs to be accounted for. And so we have a number of evidence-based strategies. I'm not going to go into these. I've just listed them just so we understand that evidence-based strategies exist for both treating and trying to assess, to treat, and potentially prevent suicide risk. It's really how you bring them together, and we have to have access to the people at the right time to be able to use them. And that's where we're kind of falling down a little bit as a system, is trying to have the access at the right time. So we've already heard that we can access them while they're incarcerated, but what about upon release, which is what we're going to talk about with the study. Again, a number of evidence-based treatment modalities that are also available for agencies to implement. Again, if you have access to folks and they're coming to care, it does require that people are trained specifically for it. You have to have the competencies for it to deliver them. You have to have the right supervision infrastructure within your agency to deliver them, but they do exist, right? So what I'm going to talk about in more detail is NCHATS. And so this is the National Center for Health and Justice Integration for Suicide Prevention. It's a very long name, so we just call ourselves NCHATS. So NCHATS was developed through a grant from NIMH. It was about a $15 million grant, 36 investigators, 18 institutions involved. The principal investigators for that are Dr. Jennifer Johnson from Michigan State, Dr. Laura Weinstock, and Dr. Brian Amadani. And so they lead NCHATS, and NCHATS was set up to fund 4 primary, very large research studies, and then some offshoot pilot studies that we were able to fund over time. And so the mission for NCHATS is to link criminal, legal, and healthcare system data for rapid suicide risk identification and coordinated intervention. What they're looking at is the decades-old problem that we've got systems that have data that can't talk to each other, right? So the healthcare systems don't talk to the correctional system and vice versa. Some of that's legal, some of it is just logistics, and some of it's just that data systems don't talk and play well with each other. And so they're a national hub for justice-focused suicide prevention. If you have interest in their work, it's simply nchats.org, so you can see the different projects and who's there. There's also a consortium of practitioner agencies and associations that are also involved with NCHATS, so that they always have both the voice of practitioners and the voice of individuals with lived experience at the table. So it's not just academics. There are 4 major projects. I'm going to talk about the one in the box because that's the one that we're wrapping up, that was done at CareSource. There's one to sync screening and services, so that to harmonize jail booking data with health records to identify and intervene with at-risk individuals. That's to take jail data and use it within hospital systems, one of which I believe is in Michigan and one in Minnesota, so that they can know when people they're treating are going in and out of jail, and then they can put them in specific suicide care pathways if needed, and they're testing that out to see how that works. The one I will talk about was done here in Ohio through CareSource, where we deployed 2 different interventions, the one which is carrying contacts from the MCO, and the other was sending specialized reports, which I'll talk about in more detail, that gave contractor providers in the community information about their clients who were coming in and out of jail that were also CareSource members, and seeing that they could do in-reach and outreach and do follow-up to try to get those people continuing care. There's one in, I believe it's also in Michigan, where they're looking at trying to take the same kind of integrated jail booking and claims data and deploy that, I believe, within 3 jails, where they're going to try to use an algorithm to identify who's at risk of suicide within that jail, so that speeds that process up. So we're not doing the face-to-face clinical assessment. We're using statistics basically to say, hey, you're at elevated risk, to see if that works in that environment. And then there's one in Massachusetts where they're actually working with the police department. And it's for police officers who are taking people to the ED for crisis interventions, and they're going to be doing some stuff with a navigator and using data as best they can to kind of move those interventions along and do the triage and see how that works. So the one I'll talk about, obviously, is the one with CareSource. And so as I mentioned, CareSource got involved in this work in 2018, well before the study. They were already doing the work. That's actually how the investigators found out about it, and they worked with CareSource to design the study. And so they had worked to work with a jail data vendor. They would get data from this vendor on all of their members in Ohio at the time who had been booked into or released from a jail. We would get information on what jail, and then another consulting organization would then take that data, merge it with like claims data and other in-house data, so that we could create these reports that could be used for triage and care. Now, at the time, it was new and trying to figure out like, okay, what do we do with it? And so there are individuals who talk about having MCOs do that work of outreach, but the reality is at that time, CareSource had about 43,000 people per year in Ohio alone moving in and out of jails. An MCO cannot do outreach to 43,000 people a year and do that effectively or in a cost-effective manner. And so they can't do any outreach, but to take it on themselves doesn't make a lot of sense. And it's also, they're not as closely attached to folks as community providers. And so the idea was, why don't we leverage our community providers who are already working with these individuals and start to share that information with them. The other kind of challenge too is in terms of like trying to share it with the jails directly is that they're not covered entities. And so we often couldn't share that information directly to a jail because we don't have a legal manner to do that. So it has to go to a treatment provider. And so those reports were constructed in that way, and then they were constructed in a way to make sure that we only disclose what we are able to disclose, per someone, HIPAA and 42 CFR, right, for both of those. So the goal was then to help them continue to get that community care by agencies either upon release doing outreach, or for those agencies that do have in-reach capacity, doing in-reach while the person was still incarcerated. And so the uniqueness of that is, if you try to take that to scale, right, think about how many providers an MCO works with, for example, just in the state of Ohio alone, and how many jails could potentially be impacted if we could take it to scale. Right? Now in the study, we worked with 10 providers, so it was not a scale, but the study was to start with 10. And so we were looking at approximately 44,000 subscribers in the study, and they're looking at people who passed through jail the 12 months prior to and 6 months following release. That's the time frame at which we're collecting data on folks, using an algorithm developed by the Mental Health Research Network. And so we use that algorithm in 2 ways, and that algorithm is publicly available. One is to then code the claims data to identify suicide events, but the other is on the front end is to identify individuals at elevated risk for suicide. That was one of the issues or one of the pieces of data that were put into the report. And so while we trained all the providers in the study that everybody coming out's at elevated risk, like every single one is at elevated risk, there are people that rise to the top of that list, and the algorithm would tell us who's at the very top. And the reason we did that was in the event that a provider couldn't do outreach for everybody, that they would prioritize those folks, and at least do those folks first. Now the reality is when we rolled it out, the providers all tried to do everybody. That was what they tried to do, but we had that in there so they would have that algorithm. And so that's the same algorithm that's being used in the hospital-based study as well. And so what we did is we had, again, 2 studies. The first one randomized about 44,000 Ohio CareSource subscribers to a caring contact condition, which we're going to be talking about. Anybody heard of caring contacts? One person? Any of you had a procedure done and you got like a nice little handwritten note or a card afterward? Okay, that's a caring contact. Now, they're not always done for suicide prevention specifically. So for example, in the course of this study, I had like a ginormous kidney stone. Like I said, the first time I ever get one, and it's like, they're like, this is the biggest thing we've ever seen. I'm like, of course it is. I was like, because that's how I roll, right? So it's a huge thing. So I have to have, surgery and whatever. And after the surgery, I get this little card in the mail, and it's personally signed by every one of the people that were part of my team. Right, and I got it. I'm like, oh, that's so sweet. And I'm like, oh, and I know what this is. Like, I know what this is now. This is a caring contact, right? Or my husband, who years ago he had LASIK, and I will never forget because I still tease him to this day. Like he would not get it done. Would not get it done. The idea of a needle coming at his eye, he couldn't take the thought of it. He's like, they just need to knock me out. I'm like, I'm afraid your eyeball's going to roll back if they. I don't think they can do that. Right? So, but he finally relented and he did it. They had, and this woman, her actual title was to be his designated hand holder. Right? She sent him a card afterwards. And I remember to this day, her name was Amber. So she was like, that's how she signed it, from Amber, your designated card holder, hand holder, right? Again, they're not doing that for suicide risk. They're, and some of that I would argue for them is also just good customer service because it's an elective procedure. But that person's there purely for your care, for your comfort, and to have someone that, like, if you're feeling that you need more help, that you would know to reach out and you'd feel comfortable. When those kind of caring contacts have been done in like post-release psychiatric hospital scenarios, they have been shown to reduce suicide. They're one of the few preventive kinds of activities that have empirical evidence to show that we can prevent suicide through these kind of low-touch, low-expense methods. And so CareSource was interested in what if we did that from an MCO perspective at scale. And so that was one study. And the other study, as I mentioned before, was sending those weekly reports out to those 10 agencies, so for 6 months at a time, every week, so that they could do outreach to their folks. And so for the caring contacts piece, again, this is just some data showing that since this, these have been around since the 70s. We do have randomized control trial data to support their use. They have been shown to reduce suicide risk in various populations. However, what they've not been done at is in the mechanism in which CareSource did it, which is, again, these very large numbers, and they're not handwritten notes, right? We couldn't do that for 44,000 folks. And so we wanted to test to see, does this work? So what makes a caring contact? It is a periodic outreach. They are meant to be non-demanding, so they cannot look like, right, like what our brochure, like you can't send someone the brochure from an agency and go, here's our 22 services, right? And here's how you call, and here's your referral, and here's what you need, and here's your paper. Like that is high demand. So those are high demand touches. This literally is, hi, we care about you, we're here for you if you need us, right, kind of thing, we're thinking about you. The 3 core principles is that the contact's initiated by the provider, not the patient. The messages are supposed to be over a long period of time. So again, like the one I got from my surgery, it was a one and done. So that's what I mean. It wasn't truly a caring contact in that sense. So they're meant to be over time, multiple contacts, and continued contacts not contingent upon their response. They don't have to have done anything. We're going to continue to reach out for a period of time. And so in our study, the duration of the entire study was 2 years. We did, again, I think it was just over 44,000 folks. We randomized them in 2 conditions, caring contacts, business as usual, and then they got a letter once a month for 6 months was the protocol. The letter did not mention they'd been in jail, did not mention that was the reason for reaching out, but it did provide information on accessing help, but it was a single number. We did not give them a whole list of things to choose from. It was like, here's our 24-hour nurse line, it's free if you need us, we're here kind of message. And then the outcomes are using claims data to look at things like medically treated suicide attempts, all-cause injury, whether people are showing up and going to behavioral health outpatient, did they use that CareSource 24 nurse line, what's happening with ED visits, and return to jail. And these are just the things that we need to consider when we're designing caring contacts. So, depending on your target population, that's going to impact message content, for example, your delivery options. So again, we did ours monthly for 6 months, but how often are you doing it? And the modalities. We did a letter, and as I'll show here on a slide, that was due to feedback we got in focus groups, if that's what subscribers would want. That's not what we went in thinking. We were thinking more like a postcard or something along those lines. Partially because we were worried that people would get a letter that from your health insurance plan looks like a form letter, don't even open it, goes in the trash, right? But that's the exact opposite feedback that was given in the focus groups, right? So we did a letter, but they can be text messages. Text messages are often used now as caring contacts. They can be other mechanisms that you have to tailor for your population. And so again, I did not personally work in the focus groups, but Dr. Sari Arias ran those. Those focus groups were done with both practitioners and with people with lived experience who were CareSource subscribers, to get feedback on those kinds of things that they wanted to see. And so there were a number of things that they stressed. One, again, was that don't give me a bunch of stuff. It's the emphasis on the fact that 24 line was free. They wanted to make sure that we emphasized that the resource was free. They are the ones that I mentioned that said that if I get a letter in the mail from my health insurance provider, I'm likely to open it, so make sure it's a letter. So we got some really good feedback, and they were given examples of things to read as potential content, and we were able to give that feedback to say yes or no, that wouldn't work. It was also things related to how you sign off on the letters, like your greetings. So we don't say like, dear valued member, right? A caring contact doesn't start off that way. A caring contact says, dear Kim, right? Which is not how most mass letters at 44,000 go out, but we did have to tailor them in that way for the project. So again, these was just the overview for the focus groups. So these are some examples. This is how short some of these, the actual content was. That wasn't about the 24 nurse line. So they did get 6 different versions, even though they're very similar. They got a different letter each time. So it might be, Dear Kim, sometimes we need someone to have our back. We are here for you if you need anything. You matter to us. That's the message. And then there's a little blurb about we have this free resource, the 24/7 nurse line, and here's what you can get from it. Like if you need these things, call this number. And then because we couldn't sign it from a named person, I think we signed it from their care team, something along that line. But so it was meant to be a little more personal. It obviously couldn't be as personal in this environment as a handwritten note from a clinician. But these are some of the things that we talked about. So we thought we'd reach out to check in. We care about your well-being. Here are some free resources that might be helpful. The other thing we stay away from is that language that also makes it sound like they might be struggling. So we everything's supposed to try to stay positive in that frame, not make assumptions, but just be like, we're here for you if you need us. And then, as I mentioned, the other study were the reports. And so this was was designed to be 12 agencies, but we were able to get 10 who fully participated. They were in what's called a stepped wedge cohort design. So we'd have 3 or 4 agencies come on, and 2 months later we'd bring on another 3 or 4 agencies and another 3 or 4, and they would each be in the study for 6 months. And during that time, they would get reports on a weekly basis, and those reports would contain, as we mentioned, all of their clients that we had that were also our members who'd been booked into a release from jail. They would get data on whether they had an SPMI, whether they had a substance use disorder, again, if we were allowed to share that. They were told whether that substance use disorder was opioid use disorder specifically because of the increased risk for overdose. They were given what facility they were in, what jail they were in, if they were released, how long had they been there, so they would understand how long someone had been incarcerated. We would have data on their last visit date for outpatient, for example, because these are all outpatient facilities. They were given information on health usage, healthcare usage information. So in the last 12 months, how many times had they been in an emergency department? How many times that they had unplanned readmissions? How many times that they had been, I think, inpatient? So they got a whole host of information to use. The study only asked them to look at the suicide risk algorithm, the data release, and do outreach. That's what the study asked, but we gave them everything we had in the report in the event that they could use it clinically for triage. The study also only focused on people that had been released. That was the request. However, because we had data about people still incarcerated, we also included that data. So this was all in an Excel workbook, so they had a separate tab for incarcerated individuals. So if they had the ability to do InReach, they could simply move to the other tab, see which of my clients are now incarcerated, where they're at, because they weren't always in that county's jail, right? We had people from all over the country. So, you might be in Butler County, but they're in jail out in California somewhere, and now they would know that. And so many of the sites gave feedback that was very helpful. Even if all they ever did was alert the clinician that, keep an eye out because we're going to be watching this report to see when this person gets released. Don't close their case. And then that you'll know that when they're released that you should be screening for suicide. They were meant to do suicide screening at the point of calling. I will say that didn't happen very often, so we can talk about that. It was really more common they would get them back into care and then do suicide screening. But that was the idea. And the staff at each of those agencies was trained in the Columbia suicide screening instrument in the event that the agency didn't already use that. They weren't mandated to use that specific tool, but they were trained in it, and they were trained in evidence-based safety planning so that they would know how to do that when it was warranted. And so this is the stuff that I just talked about. This is what happens when I get ahead of myself. So this is just the stuff that was in the report. So in terms of the way it got rolled out, we did a lot of implementation science work with these sites. So I personally met with every one of these sites weekly for a month and then monthly for 5 months. So we had lots of meetings for that 6-month time frame with all 10 providers. Some of the things we saw, a lot of heterogeneity across those sites in terms of size. So we would have some very small agencies that really served like one catchment area, and we had agencies that were very large and served upwards of 10 different counties. A lot of RCTs tend to try to control some of that, where like all the agencies would have looked very similar. We took a more pragmatic approach because real world doesn't look like that. Real world has a lot of variation, and so we had and from an implementation standpoint, you get richer data to understand what it means to roll these things out if you have different kinds of agencies. They differed in terms of how they handled the responsibility for managing the reports and triaging the information. So we left it up to them. Some sites, one person took the report, they looked at it, they assigned it out to the various people in the organization, and they triaged it. Some of them took the report, not only did they triage it, but they did all the outreach. And that was more common in smaller organizations, where like if I was the one taking it, I did the outreach for everybody, regardless of who clinician was attached to that client. Other agencies sent it out to each clinician and said, you do the outreach. So again, we left that up to them. Again, I mentioned conducting the suicide screening at the point of phone contact was not common. I think people really were not comfortable. We did create some scripts, which then helped with that a little bit over time. I think suicide screening in general is not comfortable for a lot of clinicians, let alone over the phone. They did at least ask a couple of questions, and if it sounded as if the person might need help, they would go further with the screening. And then the more common approach was to get them back in and then do a full screening upon their next appointment. Larger agencies had more manual work to do to locate their clients in their EHRs. And so I can speak to that a little bit directly. Tabor House actually was a participating agency. We use CareLogic as our electronic health record for our behavioral health outpatient programs. So all CareSource can do is say this is a Tabor House client. They can't say what program that client's in, because you don't bill that way, right? We have one MPI that goes to Tabor House. And so then Tabor House would have to look them up in the EHR to figure out which program is this person in, who's the clinician. Very manual process. We did try to create a query, and we got 75% of the way there. So because the idea was like, could you just copy up that Excel spreadsheet, copy those clients' names, plop it into CareLogic, and run a query, and then it pops out a report. And it got us part of the way there. The problem is, again, because of the different way that services are coded, it didn't always get us right down to the exact right staff, and so there was still a decent amount of manual work that had to be done. And we had other agencies that looked like Talbot using the same EHR that were doing the same thing. So it did take a lot of manual work to be able to identify where that client even was to be able to do the outreach. And they all varied in terms of how they approached clients who had already been discharged from care. So it wasn't uncommon that that person had already been discharged from their services. And so some agencies were not comfortable doing outreach at all to folks who'd been discharged, because they felt like it was like a cold call. Others did do it, but within parameters. So some would say, well, we'll do it as long as they've only been closed for 90 days or less. We had one agency said, we're contacting them all. So it's like they all kind of did it different. And we left that up to their agency policies. And so right now, the preliminary outcomes for caring contacts, which I don't have a slide for because we don't really have any at the moment, is that the first analysis does not show a statistically significant positive outcome related to the caring contacts. But we're not done with the analysis. So part of that's because what they do is they take what's called an intent to treat approach for analysis, which means the whole 12 agencies get included in that analysis, even though 2 of them didn't participate at all. Because that's what intent to treat does. It's the most conservative approach to looking at outcomes is you take everybody, regardless of whether they got the intervention or not, if they're in the study, and you look at their outcomes. And so we're not seeing an effect. Now, there's additional analyses that they're planning to do. So, for example, we've not looked at the difference between people who did, in fact, get letters and those who didn't. We do have some data to suggest who did and didn't get letters. So part of the protocol was if we got 2 return to senders, we stopped sending letters. So we know those folks didn't get letters. We had people that their status changed over time. They were enrolled at CareSource at the start of the study, midstream, they were disenrolled and therefore couldn't get any more letters from us because that's not legal. And so those people, we had folks who, just for me, just eyeballing thousands upon thousands of addresses, could tell that they weren't residential. So 4545 Fisher Road was very commonly used through DRC, through APA. I think I found more than 1,000 instances of 4545 Fisher Road. We had lots of county JFS offices that were used as the address. I recognized Tower House addresses when I went through the list. So we're hopeful that they might be able to look at analyses based on who probably got letters versus who probably didn't, and they may look at who had used that nurse line prior versus those had not to see if that makes a difference in terms of whether people were calling the nurse line and things like that. So there's more analyses still to come in that space, but so far we're not seeing an impact for that. And even if we don't, it could also be down to things like, would texting have worked better? Like there's still other questions that could be answered in future studies. In the report condition, though, we're still very preliminary in the outcome analysis. They are showing some positive, statistically significant trends. And right now, at least, again, pending further analyses, they are showing an increase in outpatient behavioral health visits post-release from jail. And they are seeing a decrease in all-cause injury claims, which are often associated with suicide attempts, and they are seeing ED visits go down. So we are hopeful that that report mechanism is showing an outcome by the time we're done. So just in conclusion, we know that suicide risk is significantly elevated again among people who are involved in the justice system. We know mental health, substance use, trauma, fragmented care are all major risk factors. We do have a slew of evidence-based interventions that we can potentially use. The issue is we need to know when people are going in and out of jail. We need to be able to connect with them very quickly to maintain that connection and that care continuity. And one way of doing that is these data sharing kinds of cross-talking across these systems in ways that we've not seen before. And so there is infrastructure that's been developed. I will say, there's a lot that goes in that. It's a very costly thing to put together. I will say CareSource was very innovative in that space. I don't know if we have any other Medicaid entities doing something similar, although I wouldn't be surprised to see more of that work coming down the pike. But it does take some commitment and some resources to stand those things up and to maintain them. And because even on our side, sending those reports out was manual. Right? We had a person sending those every week through an SFTP. They did work before I left. There were some parts of that had been automated, so at least the reporting part became automated. But that delivery still is not an automated process that I'm aware of. And so we do have this ability if we can get these things tested at scale. So the next steps for this study is that we will be finishing the outcomes, and we hope to be able to then release those. And then the next step will actually be looking to see if we can do an implementation trial of some sort. So this was testing out, do these things work? The next step is usually to get some type of grant to test some other things out in a real world application from an implementation standpoint, and whether that looks exactly the same as working with an MCO or doing something more in the community, that will be the next step for these projects. So if anyone has questions, happy to, as we hang around when we're done, to talk about this in more detail. You can connect with me on LinkedIn, but just happy to be here and be able to share the work. Thank you.
There are 72 people online, by the way, and so we're so grateful to the State of Ohio Public Library for allowing us to use these facilities to have this hybrid meeting. I'm going to go ahead and introduce my next speaker, Laurel Domansky-Diaz, the Justice and Health Equity Officer at Cuyahoga County. I met Laurel back when she was with Metro Health, and they were doing nationally cutting-edge things in the Cuyahoga County Jail, which, when you think about it, that's a big city. Cleveland is a big town, and they were able to make some significant progress in many areas. But I'm not doing formal introductions, so I'll let Laurel introduce herself a little bit more, but please join me in welcoming her now.
Yes, good morning, everybody. As Dustin said, I'm Laurel Domansky-Diaz, Justice and Health Equity Officer for Cuyahoga County. Prior to this role, and I joined the county about 18 months ago, but prior to that role, I worked for Metro Health for 5 years. I ran the correctional medicine program in the Cuyahoga County Jail. And prior to that, interestingly, connecting to Dan, I worked as Chief Operating Officer for Neighborhood Family Practice, which is an FQHC in Cleveland. So I have kind of all the backgrounds of the topics that we've been talking about today. But I'm really excited to be here today. I'm honored that that Dustin invited me to be a presenter, and Justice Stratton. We are doing some really innovative work in Cuyahoga County, and I think this presentation fits well with what you've already heard today. I do want to give a shout out to our colleagues and friends in Franklin County, because you'll hear a couple slides, and I will point them out, some ideas that we have, that they actually initiated that we're collaborating on and thinking about too. So just really happy to be here. So today I'm going to talk a little bit about what we went through in the Cuyahoga County Jail since 2018. And so I will get to that slide in just a moment. I'm going to highlight some of the current offerings and services that we are currently providing in the Cuyahoga County Jail and in our justice system, and then talk about our future system enhancements in our new jail planning. So my role and why the county executive brought me on to his team, and I do want to point out, so we have one county executive in Cuyahoga County, where I know a lot of your counties probably have a three system county executive or structure. We do have one county executive in Cuyahoga County, and one of his charges early on as he was elected was that he needed to kind of start and complete the building of our new jail. Our current jail was built in 1965, one tower, and the other tower was built in the early 90s, I believe. Both of them are very antiquated. Those of you that work in jails know the 24-hour, 7-day-a-week wear and tear that happens in jails. And so we've been really focused over the past year on trying to, to plan for that new jail, which we will break ground on hopefully later this year. And then finally, just some thoughts about system reform, which again tie really closely with my previous presenter's work. Okay, so I just want to talk a little bit about where we've been in Cuyahoga County. Some of you that have followed our history know that in 2018 we had 8 deaths that occurred in the Cuyahoga County Jail. About half of those deaths were due to suicide. There were some withdrawal related deaths and a health condition related death. That was just an awful year for our county and for our jail. At one point, the feds did come in and say that if we did not turn around our correctional medicine program, that they would have to intervene. And so Metro Health, which is our public hospital in Cuyahoga County, was charged with, or asked to take over the correctional medicine contract. Prior to that, it had been kind of a meld between county employees. Metro Health did have the doctors in the facility, but one of the big changes that had happened in 2018 is that we had taken on the City of Cleveland contract. So that prior to that, City of Cleveland had its own separate jails, and in 2018. The two merged, the county and the city jails merged, and I think that the county jail just maybe perhaps was not prepared for fresh arrests. And those of you that work with fresh arrests know that people that are coming straight off the street are very challenged, especially from a mental health and substance use disorder perspective. So we really had to look at all of our processes, all of our staffing, everything, from A to Z. Policies and procedures, and really think about how we were providing care to the people in the facility. So in May of 2019, that's when I joined Metro Health, and walked into probably one of the most challenging professional experiences that I've ever had. Day 3, we had somebody commit suicide in the jail. My day 3. And it really was just a eye-opening and just shocking experience for me, personally and professionally. And it just really hit home how much work we had to do to reform the system. So throughout that summer, we did a lot of work around staffing, again, policies and procedures. We implemented our electronic medical. We had an electronic medical record system, but we did not have our medications on that system. So we were using a paper MAR, but an electronic medical system, or the EMR, the Epic system. So, made that whole transition happen over that summer. And in October of 2019, we did, after that full review of our correctional medicine processes completed, one of the key things that we did, and I'll talk a little bit more about that, is that we added full behavioral health and addiction screenings at intake. So again, those of you that run correctional medicine programs are familiar with them. We pulled all of our screenings to the beginning of somebody's experience in the jail. So we did not just do the receiving screening, we went through like the full 14-day health assessments so that we could ensure that people that had any kind of conditions, any risk of suicide, any risk of withdrawal, we could identify that right away and get them the care that they needed within a very quick time. So in October of 2019, we did come in compliance with all of the ODRC medical, I should have put medical requirements there, but because we do, our facility is challenged to come into full compliance with all requirements. But we were able to accomplish that in 6 months, which was a huge undertaking for us. Of course, April 2020, we had our first COVID case in the CCJ. We worked very closely with our Common Pleas Court to reduce our jail population from a high of 2,200 to 900 people. And we do think that allowed us to have, as much as possible, a pretty successful COVID experience in our jail. We only had 1 death that occurred in our jail. And so we had a lot of, had just developed all these new policies and procedures, and then had to revamp and think about, how to adjust and to this new, normal. In June of 2021, we earned our first NCCHC accreditation in 20 years, and that was one of the key parts of the contract that we had worked on. And then as we continued to move along and continued to enhance our services, in the fall of 2021, we received some opioid funding through the county to expand our addiction services in the jail, and I'll talk a little bit more about that. But we added a specialized withdrawal unit in October of 23, and then I moved over into this role in April of 2024 with really the vision of trying to continue to move forward, think about how we're going to design this new jail in a more humane and rehabilitative way, and really through the health lens, because that is what we're dealing with. I'm sure, as is the case with most of you, 70% of the people that are in our jail have some mental health or substance use disorder. So we really need to think about that as we plan for the future. So some of the current offerings that we have in our system and in our jail is that we do have specialty dockets. We have drug court, MHDD court, we have a veterans treatment court, we have a domestic violence court docket, and all of these court dockets work really closely with our jail liaison program, which is five different jail liaisons that come from our community behavioral health agencies that identify folks while they're in jail that can benefit from a more intensive kind of case management support, as well as treatment while they're in the jail, but more importantly as they leave, making sure that they're connected to community care and are receiving support through those dockets. So many of these dockets will last a year or longer. Folks have to come check in based on their different types of sentences and programs and support that particular court is providing. But I for one have been really impressed over the past year with just learning more about the dockets and how comprehensive the support is that people receive that go through them. I'm sure that there are other counties that have these types of dockets, but I do think that that's one of the key pieces of the work that we do in Cuyahoga County to keep people out of jail and once they have received their sentence and they get involved with the docket, staying in treatment and staying connected to the community. So I mentioned in terms of jail programming, we do the comprehensive screening for medical, psychiatric, and substance use disorder at the point of intake. We provide medications within 12 hours of arrival, including an on-site methadone distribution program that we have through a contracted agency. And we have dedicated mental health units and withdrawal and treatment units for substance use disorder. One of the reasons why we're building a new jail is that those spaces are pretty limited in our current jail. So it's on one floor. We have, I think, maybe a total of 75 to 90 beds on that floor to manage all of the folks that are, coming in with these conditions. Like I said, we're up to 70% that have some level, 40% have some level of SPMI, up to 70% when you start to look at SUD as well. And so as we think about our new jail, we're really expanding the programming and the services that will be available for the population. Just listed some of the staff that we have on site every day through our contracted medical provider who is still Metro Health. I also want to point out that we recently received a grant through the Office of the Ohio Attorney General's Office, which is allowing us to expand our peer navigator services in the jail, or rather to add them back through a partner agency, and we received that grant in July of 2025. So we hope to have that program in place in the next few months. But we used to have peer navigators in the jail prior to COVID. When COVID hit, we had to, shut down some of our programming, and the agency that was providing those services lost their funding, but we were able, through the generosity of the Office of the Ohio Attorney General, to add those back. Something else that we're working on is our frequent system utilizer work, and this is where I want to give a shout out to Melissa Pearson and her team, because this was really an idea that helped us formulate in Cuyahoga County, that something that Franklin's working on as well, is that really looking at the people that are cycling through the jail on a frequent basis and trying to intervene and trying to figure out how do we get those folks attached to care, connected, because they are one, the highest utilizers of not only the justice system but our emergency rooms and our homeless shelters, and trying to make sure that we can intervene while they're in jail as much as possible to try to break that cycle. So we're really preliminarily in this work right now, but we have identified that there are about 300 people in our system that have had 8 or more encounters in the jail over the past 3 years. They do have a higher than average diagnosis of mental health and substance use disorder, not surprising, and many of them are also found in our health management, or our homeless management information system. So they've had some engagement with being unsheltered. So right now we receive a weekly report that's generated by the jail that identifies if these 300 people are in the jail. Which of these 300 people are in the jail. And normally it ranges from between 30 to 50 of the 300 are in our jail at any one time. So what we do is we send that report out to the correctional medicine team, to our public defenders, to the Court of Common Pleas, and our reentry workers in the jail, so that they can engage with the residents and assess what types of resources are needed. So we, again, like I said, we are preliminarily in this work, and we're just trying to gather data at this point in terms of determining what kind of assessment we need to do, what kind of things that we need to pivot on. But the impact of the work ongoing is something that we are going to continue to watch. Another big addition to the work that I want to make sure that we highlight too is our addiction and withdrawal unit that we have and services that we have in our jail. So we have a specialized unit on the 7th floor of our jail that provides anybody that comes in with an SUD, substance use disorder, and is actively using, is housed in this unit if they're a male. In one unit, obviously, if female's in another unit. It is a dorm type setting so that we can have eyes on anybody at any time. We make sure that there's very intensive services that are offered to folks. So they do receive, daily addiction counseling. There's medic and nurse rounds several times a day. They do receive MAT treatment options, including if they're on methadone, like as I mentioned, that they receive that as well. We make sure that our custody staff that are in that unit are well trained on signs and symptoms that they need to look for, and just have more kind of trauma-informed care approaches to the work as well. We have patient navigation services that are available in that unit as well, and then we offer jail liaisons the opportunity to go in and work with folks if they need it, as well as there's an opioid addiction team that provides connections to ongoing treatment and post-release. One of the unique things is that we offer substance abuse groups as well, and some of those are peer-led, so the guys that are living in the unit will actually lead some of the substance abuse groups that we're doing. And so that's been a really kind of positive thing in terms of like people looking at each other and saying, hey, I see this, you've been able to do it, so maybe I can do it as well. A little bit of initial outcomes on this work is that, so in 2021 we had 1,179 people served by this program. But in 2022, 140 of those people came back. And what we found is after we linked them again with addiction counselors in this more specialized way, 96, let me see, my screen was a little blocked up there. So 70%, almost 70% of the population did not return to jail in 2023. So we're continuing to track that and seeing where the impact is, but we can see that when intensive treatment is provided in the jail, that we're having success with people not coming back. And I think that that's the ultimate goal of a lot of this work. There's a couple quotes from participants as well. So moving on to, future jail programming, vision and goals. So I talked about that we are really trying to focus on a humane, rehabilitative, and healing experience for any of our residents of our county that end up in the county jail. Number one, we want to reduce the jail population by ensuring that all diversion efforts have been fully vetted prior to incarceration. So we do have a diversion center in Cuyahoga County. We're probably shifting that model, working to shift that model to more of a crisis center approach, which I think a lot of, at least a few counties in Ohio, I know Franklin again is working on that, because we really want to be able to expand the types of services and really open the door very wide. Our current diversion center has some criteria and restrictions that sometimes don't allow people to actually go into the facility. So, looking towards the future, we are looking at more of a kind of crisis center open door model. We also want to make sure that every resident that comes into our jail, that all of their needs are met from a health, social, and rehabilitative perspective. And we want to really work on the reentry piece as folks move back into the community. So I think this is somewhat of a repeat of what I just talked about, but just making sure that folks that are diverted, that are appropriate, get the care that they need in the community. We want to create a facility, of course, that meets all ODRC requirements and develop comprehensive programming within the facility, which prepares people for release and reentry. And then I'm going to talk a little bit about our reentry center too. So future jail programming, all of the spaces that we're creating, all the housing units that we're creating in our new jail will have opportunities for individual and group programming on the housing unit. That is so that we don't have to transport people to specific places to receive the care that they need. There will also be digital opportunities either for telemedicine or programming that might be happening in one part of the jail can be projected into multiple programming rooms throughout the facility. And that is really to kind of maximize all of the resources that we have available. And again, if we don't have to move people out of the housing unit to get programming, we can bring the programming to them. It's, you know, smarter and more efficient from many different perspectives. We have rec units on every housing unit as well, and those will provide opportunities for sunlight and fresh air. Right now, our rec units are on each floor, and so, you know, that people have to be physically transported to the rec unit. Many of the rec units don't have windows. So this is, again, a place where we can provide both operational efficiency, but more access for people to have kind of more of a normalized environment. And to that point, we also are using a lot of therapeutic uses of color and light throughout the facility. We want to have soft furnishings and fixtures to just kind of bring the temperature down. I'm going to talk a little bit more about the Behavioral Care Center and Reentry Resource Center. And then the last piece is we really want to bring different types of programming that around vocational services and educational programming into the jail. Though most folks are in and out within, you know, 7 days to 2 weeks, we do have people that are sentenced in our jail that stay there, you know, upwards of a year. Right now, I think we have about 150 people that are serving sentences in our jail. And we also have people that are awaiting trial. And so if we can help prepare them better to go out, you know, even if they end up in prison, it's, you know, it's better for all of us as community members to be able to do that, you know, work as quickly as possible. So our Jail Behavioral Care Center is going to be a behavioral care unit that's within the secure perimeter of the jail. So we will have regular behavioral health, you know, housing units that might look like your typical jail, though we hope a little bit more friendly and soft than your typical jail. But this particular space will look more like a behavioral health hospital. And the idea is that we would do a lot of intensive programming in that space to, you know, to provide treatment and care in a setting that's more conducive to that type of work. So, again, providing a humane and healing environment for intensive treatment as an alternative to traditional jail housing and treatment. Our intention in this unit is to not keep people in jail that can otherwise be released and served in the community. And this is really important because one of the kind of feedback that we have received from folks is, oh, well, wouldn't people just want to stay here and get their treatment here? And it's like, no, you know, that's not the intention. That's not the goal, to keep people in jail longer than they need to be in jail. But if they are already there, we need to make sure that they get the services that they need. Or if they're awaiting, you know, treatment placement and it's going to be several weeks, can we start to, you know, stabilize them in more of a normalizing environment? So our target population is, again, not folks that are served by other programs or can be served in the community, but really folks that are already in jail that would be benefit from it. We are exploring the idea that some people may choose to participate in the programming in lieu of conviction or be given the opportunity to reduce their charges or sentences based on whether a judge approves that. But that is something that, you know, that we are in community conversation with our different judges in our community. We're also exploring some opportunities to offer psychiatric evaluation and stabilization for less complex cases, and that's something that I know Harrison County, I don't know if anyone's here from Harrison County, but Harrison County I know is doing a pilot on that with the Ohio Department of Mental Health. And so we are trying to think about, is this a space that we could start to offer some stabilization so people don't have to be, you know, transported out to, in our case, it's North Coast for the most part. Now again, that's an initiative and concept that we really need to work through, but we know that that's a pain point for our judges in terms of like having to get that stabilization done and waiting for that placement. In Cuyahoga County, our average length of wait is about 40 days. I know in other parts of the state it's much longer, but that is something that we, you know, want to talk with both the state about and our judges and our jail staff to see if that's something we can do. So I wanted to show some imagery of what the conception of what we're looking at for some of these spaces. So just to point out, at the rear of the picture there, you see the rec area. So, you know, lots of light, lots of glass. The windows up at the top will open. Obviously, these will be up high, so you can't jump out of them or climb out of them. But all of the rooms in the behavioral care center, and so we'll have about 60 beds in this space. So 2 24-bed units and 1 12-bed unit are dorm style. And the doors on the units do not lock. So even though there will be separate rooms, they are kind of like free to come in and out of the spaces. On the left-hand side, you'll see doors that are where we'll have either individual therapy rooms or group programming rooms. And then again, just we're trying to use like the soft furnishings, the light, the color to kind of just bring the temperature down in the spaces. And then this is an example of what our withdrawal unit will look like in the new jail. Again, you know, dorm style, lots of ability to see what's happening in the beds, and that's why we kept the walls low. We want to make sure that the officers and any medical staff can quickly glance and, you know, walk up and down and just see how people are doing, so that we don't have anyone suffering, and we're not aware of the situation. And again, you see the rec room on the end there. And then finally, our Reentry Resource Center this is a conceptualized drawing of that as well, is a space that everybody that leaves our jail will walk through this space, and they will have the opportunity to get basic needs met, whether they need transportation or they need housing, or they were, you know, came into jail in July and are leaving in December. They can get a jacket or a sweatshirt or whatever it is that they, you know, might need to you know, leave the space comfortably. We'll have phone charging stations, so, you know, basic things. But also we want this window that you see right here will be a place for our medical team to provide prescriptions, notice of appointments as people are leaving, if they have, you know, appointments out in the community that are already scheduled. So really just trying to kind of close that piece of, you know, information gap that often happens when people leave. Some of the programs that we've talked about today around the 1115 waiver, being able to provide prescriptions and making sure that you know, that continuity of care is there, is really important for us. And unfortunately, the way our jail is designed right now, it makes it very difficult because people, you know, get released. We don't know what time they're leaving. They just, you know, walk out the door. Where this will be a place where everybody will at least have the opportunity to stop and get information. We will not force them to stop, of course, but if they want to, the information will be there and the resources will be there. In addition, we're exploring the idea of having probation co-located here. We may have vocational services available, reentry workers available as well, and making it really a resource center for, you know, anybody that's going back into the community to, you know, to gain kind of all the possible resources that they might need. So system transformation needs, I think you've heard a lot about this today, and I think that we fit well in with what's already been discussed. We definitely want to continue, you know, collaboration and coordination across the continuum, and we're really trying to work hard with our partners in the community to make sure that those things happen, whether it's through a crisis center, as, you know, for people not even to come into jail, or working with our jail liaisons or our correctional medicine provider to make sure that as people leave that they're connected to care as well. We want to do support for workforce development, so some of the programs that we've talked about, or that I talked about in terms of vocational training. So we're in discussions with our community college. We're in discussions about having a kitchen, a culinary program in our jail, whether that's on a screen or people actually come down physically to a kitchen space. We are working on, you know, different types of things around that. We want to support Medicaid waivers and other initiatives that provide resources for jails to be reimbursed for services, to Dan's point. So, you know, anything that we can do to, you know, help support payment in a way that is productive for everyone that is, you know, involved. I think that jail medical is very expensive. We all We all know that, sitting here, it's a big burden for a large county to take on, and I can't even imagine a smaller county and the challenges that come with that. Unfortunately, I think in a lot of cases, people may cut services, or they may not have things available that we would like to because of that. So I think Medicaid waivers would be really beneficial for these populations. Also, resources for housing. I know that there's a housing working group in this committee. I know that we find that many of the folks that are cycling through our jail also need resources around permanent supportive housing or transitional housing. So, working with our partners around that is going to be really important. And then finally, talking about offering the psychiatric evaluations and stabilizations, in the jail or in the community, so that we don't have to wait for our state hospitals to find a bed that's available for folks. And that is the end of my presentation.
Question for Laurel. Before individuals are hitting that, theoretically, before they're hitting the resource center, how much discharge planning has happened before they hit that space?
Sure. So, right now we have just in the past year implemented reentry workers into our jail. We have there are 2 almost full-time workers. We are intaking between 60 to 80 people a day and releasing 80 to 100 a day. 2 intake workers are not enough. So we are really trying to think about both how to expand that program, but also using our jail liaisons and the existing, programs that we have in this space to try to work on that discharge planning. I think we do a good job right now with definitely the people that are in the dockets, people that are involved in the withdrawal unit, and our higher risk folks with SPMI. But there's a whole nother population that really are not, that we can't touch just because of a lack of resources. I think things like the Medicaid waiver could help us be able to afford more folks to do that work. And really helping the system to understand the long-term cost savings by intervening at that point. To Judge Stratton's earlier point this morning, if we don't have that long view of how we can overall save the system expense, then it's hard to do any of this work. But yeah, the intention is to begin that work while people are still in the facility.
I just had a question, kind of all tied to the 1115 waiver. I feel like the 3 of you are the Avengers for health services. If you could just join forces, we can fix all these issues. So the 1115 waiver is kind of, I've been working on this crusade for, I feel like 3 years. And, we're getting closer. Our legislature put it into law, which means that nothing's been done. They have held community.
Right, there were listening sessions.
So they have had listening sessions, which are all required to do. But my question is, and I watch all these states who, are still trying to implement it. So they got approval and they still haven't figured it out. I'm just curious from all of your vantage points, whether it's care source experience from you or the on the boots and the ground on jail, or the work you're doing nationally. But for me, I would be a terrible bureaucrat because I hate bureaucracy. But I feel like the private sector can make this work if they're just given the opportunity to do it. So with 1115 waiver, however we write it in Ohio, because they've been making it very complicated. But once that is done, you would think the private sector could come in and go, the insurance companies know how to bill, the federal qualified health clinics, they know how to bill these services. And that seems to be the problem that government has, right? They can't figure out Medicaid billing. They can't figure out, and if I was a jail, I would say, hey, whatever the Metro Health is, you know what? We're getting rid of our, $100 million a year medical department. We're going to partner with Metro Health to come in. We still have to do our intake stuff, but anybody who indicates to have a medical issue, whether it be suicidal, whether it be detoxification or whatever the issue is, you would think they'd say, well, we have someone here to help you today, but you have to become their patient if you're going to qualify out there. But you would think the private sector could figure this out, could come in and help, because jail, sheriffs don't know, I hardly know, I don't know enough to be dangerous about Medicaid. But the people who have figured out how to navigate in Ohio with 5 medical care providers and all of the hoops you have to run through for billing those issues, have any of you seen any success with the private sector coming in and going, hey, state, we'll help you. We're just going to come in, we know how to do this, we just need some office space, and we'll come and do your work for you.
What I say is there's tons of people who want to take the money in order to try and make something like this happen, right? Like I mentioned, Manette, right? A giant law firm, absolutely huge, and they are immediately trying to maximize this. As they're doing it, they're not reaching out to any sheriffs, they're not reaching out to any corrections agencies, they have no idea, right? I very much believe in the power of government. Of course it becomes bureaucratized, it becomes challenging, but even though I was born in the 80s and I'm a child of the 80s, I don't hold that same sort of Reagan-esque distrust and hatred of the government. And that's because I also see so many private entities who are interested in making money, especially inside of jails and prisons, right? Think of all of the people that we contract with, Horizon, YesCare. So Coaches sends out an email every single week about how these entities are being sued, where they're being sued by, how they're changing their names in order to avoid bankruptcy. And the truth is that they've reached out to us in order to say, how do we maximize stuff out of the 1115 waiver? And the truth is they don't want to touch it. They actually kind of want to slow it down. One is because their billing rates they'll make less money billing Medicare than they make by holding hostage counties in order to be able to have this. And frankly, jails are pretty unregulated spaces. So these are healthcare professionals who don't have to follow healthcare professional rules. Medicaid is absolutely a bureaucracy, but it has things like quality assurance, utilization review. It has different metrics in order to try and once you pull in Medicare in order to get certain enhancements and payments and all that sort of thing. So what I'd say is there are people who are interested. HMA, Health Management Associates, I don't know if you've heard of them, absolutely giant organization. They started absorbing anybody who knew anything about this. They wanted to hire me, but because I'm in public service loan forgiveness and my loans aren't forgiven yet, even though it's been 14 years, not angry about any of that soon. I did not want to go and spend my life doing billable hours and all that sort of stuff. So what I would say is there are agencies out there who promise they can make this work. But this is so new that there's not an exemplar of how this has worked and been maximized and has gone off seamlessly, because 2023 was the first waiver. October of last year, so we're 1 year in to the very first counties in California did it. So there is not a heck of a lot of people who have figured out how to make this work. And so what I say is, I think that we should be very concerned when people are offering us solutions with price tags on it as well, and high billable hour rates as well too. And what I would say is also, because this is so new, I think it is a question of who understands and has a view of how these systems work in order to be able to marshal the forces to put a waiver together that works for Ohio and already has the input in from the very beginning. And then that hopefully would make it a lot easier for implementation on the other side. And already getting the word out about how an FQHC could be a big part of this, which FQHCs, although I wouldn't call them the private side, right? They are created through statute. They are, anytime we're bringing in the community healthcare system, we're bringing in government systems on top of this. Healthcare in this country is heavily regulated. So what I'd say, again, is that there are people who will take your money, of course, but there's also a lot of opportunities to be on the vanguard of what this looks like. And be wary of anyone who's promising to make it easy.
Yeah, I would just add to that I think that a lot of the correctional medicine contracts that are out there, when you're actually on the ground, one, the system is set up not to do this. The system is set up to bill for your nurse, just pay for that nurse, and I don't need to tell you all that I'm doing with that patient, So right now, I think a lot of correctional medicine contracts are built that way, just to, cost-based reimbursement. So shifting to a fee for service is going to be really hard for, certainly I think a lot of the for-profit correctional medicine providers, and to your point, may not even want to because they may make more money, this way. But the other thing is, the structure around fee for service. The way that you interact with patients when you're in correctional medicine is similar to a hospital stay, right? But there's also this kind of whole outpatient component to it. So that's why, in some way, when I talk about correctional medicine, I'm like, it's like an FQHC, except it's also a hospital. So it's like,
emergency department.
yeah, really. But then you have chronic care and you have pregnancy care. So you have all of these different, things that are happening. So peeling all that apart and trying to figure out how to, bill each individual service, finding a provider that understands how to bill, I think that, to me, that's kind of what the key is like whoever your correctional medicine provider is has to be engaged, has to be interested, and has to be motivated to, to make it happen. So
I think a lot of this comes down to, aligning incentives. When Moody and McCarthy, carved Medicaid behavioral health into managed care, the idea was to set up quality incentive structures. And because we don't have the coverage of people in jail, we're not able to leverage some of the things that we could, which sort of in its nascent stages, which is what CareSource is sort of starting to do now. They put a whole bunch of money into figuring out when their clients are in jail and when they're being released. And that makes sense, right? If it's a capitated rate and you get paid up front, then if you can prevent them from going to the emergency room and you know that that's a big risk factor when they go to jail, then you're incentivized to do that. Even if you don't have a specific HEDIS outcome measure in place to do it, the dollars and the cents work out for you to coordinate that care in that way. And I think if we can think in terms of some of those hybridized models like Partners for Kids, where you have an accountable care organization where there are partnerships across things and there's risk sharing. So you're aligning incentives. It's not necessarily about whether it's public or it's private, because nothing in healthcare is either all private or all public. It's always a hybrid. And so if we think more in terms of paying for quality and paying for outcomes, then that's why that 1115 waiver could be really revolutionary. And I didn't mean to.
I think the other piece of it, maybe what you're alluding to, Phil, is that there's also the follow-up piece post-release, right? And I think what you might be asking is there capacity for all of the community-based private nonprofits that exist in Ohio who already do these services, who already have NPIs, who already bill Medicaid, who understand medical necessity, who understand how to document. Like we already understand infrastructurally how to do it. Hopefully we'll already have all the evidence-based practices also in place and the competencies that they also in place. From that community side, there's a whole array of organizations, and because they're closer to the community than the community are better suited to work with people in these big conglomerate kinds of for-profit entities. And I think maybe that's part of the equation too. We're not leveraging what we already have, and we're not always thinking about it as a design in these systems, if that makes sense. So especially in Ohio. Lots of
So first of all, it's my first time here. It's a fantastic one, this meeting. And I'm psychology, and so I don't know all of the case management issues in the community. But I want to say, first of all, I loved everything I heard, and I'm very interested in Cuyahoga County's program. When you were talking about maybe having culinary school, other things, it's been a while since I've seen the research, but it seems to me the research I remember says that when you give somebody, or not give somebody, but when they have a bit of meaning or purpose in their lives, they're less likely to start using again, etc. And so it's not just the housing, and it's not just getting behavioral health treatment. I think we also have to help them find employment or something meaningful.
And I think in jails specifically, that has been kind of like, well, we don't need to worry about that when they're in jail. Again, back to the point that, a lot of people have just come, in and out. Some of the conversations we've had with our community college have been, hey, we can get somebody connected to a program. They can get a certificate in 2 weeks. So if they're out in a month, they know where, when they leave, they go to Tri-C and complete their, their program. And a lot of it is, it's ambitious, right? Like you have to be in a place, our jail residents have to be in a place where they're like, oh yeah, I do want to, do this, and the timing has to be tight, and you have to have a great programming director in the jail that is motivated. But I think to your point, like, yes, it's getting those basic needs met, but then to really, move the needle, we have to think about these types of things.
So, the director of Medicaid in Ohio will be done in a month. How do you think that's going to affect?
Well,
You don't have to answer that anymore.
I've heard
The timeline, a general timeline. I mean, do you think it's going to get met, or?
Well, what I'd say is that the budget has wiggle room. So it was required within a year, but they can, let the GA know what's changed about it. And when I first moved back, I was taking the temperature of how people were thinking about the 1115. First word I heard was not going to happen during this administration period. Too much things are going on. It was Medicaid unwinding, which remember post-pandemic, all that sort of stuff. And so they were just doing these listening sessions, So I would imagine that it's pretty challenging to imagine a new Medicaid director getting things. This is just me completely not knowing without any actual content, just structurally. I imagine it's pretty hard to be a new Medicaid director in the last year of an administration. You still have this requirement, but you still have the wiggle room in order to try and get out. So I don't know how this is going to unfold. I'd be really curious who they pick to be the new director. But I'll be watching it and hoping for the best. But we also want continuity, right? We don't want another administration to come in and uproot everything from the ground too. So I'm of two minds. I don't mind a little bit of wiggle room if we can go more slowly, maybe have a little bit more targeted conversations about what this could look like, how it could unfold, so that another administration maybe could pick up and be a lot further along. I would love that, but planning a year ahead in government, that seems like ambitious.
I think a lot of it comes down to refocusing on our grassroots coalition at the local levels, because a lot of these county commissioners and sheriffs have a vested interest in ways that our legislators at the State House don't necessarily see clearly unless they hear from those folks, or unless those folks graduate into becoming state legislators themselves. Phil Plummer was the sheriff of Montgomery County. He comes to that space in the General Assembly with that knowledge that, what he does there impacts them down the line. And so if we can help them to connect the dots in that way, I think that's one of the reasons Justice Stratton has been so successful, is by creating that groundswell. We can talk all day in hearings in the Finance Committee about this saving them money, but if it never materializes in 2 years, they're not really going to think about it that way. They have to balance their budget in the short term. So we got to keep the pressure on. I think not just commissioners, but I think sheriffs carry a lot of weight as well, yes. and that's why your approach has been effective.
And nationally, the two biggest players who have pushed for this have been the National Association of Counties and the National Sheriff's Association. There's also been Legal Action Center, NAMI, a lot of folks on that side. But, I think the biggest surprise and the folks who threw millions of dollars at some statutory changes and the waiver has been NACO and NSA.
So I would want to echo that. I think we had a lot of people working on the 1115 waivers, and the reason the legislature put it into law is because we weren't making a lot of progress in the other directions. So we need to keep that pressure on, very much so. And I think bringing it from the grassroots up, having county commissioners, county legislators, county senators hear the need for it and how much, especially with the opportunities that the new bill has to make it even more effective, is very, very important. So I wanted to thank our panelists, some of who traveled long distances, got up very early. Please just give them another round of applause. And a thank you to Dustin for helping to put this all together, and for our staff for putting it. And Pete and Donna, who always record these, will have this. I will have I will get out in my newsletter a link to where on my website it is. I don't know where we else put this usually. Maybe I think we might be able to get it on the AG Task Force website, but that's never quite as easy as getting it on mine. So we'll send a link out to the recording. And to all of those that have participated by virtual, we're really excited that we had such a great turnout there, and we thank you so much. And so before we leave, I would like to suggest that you all grab somebody that you might have just met or need to reacquaint yourself with and go grab some lunch since you have some time for lunch. I've made a few grabs of my own, and they're in trouble because there'll be homework for them. But we're very excited that so many came in person as well, and we hope you took something away from the program and the project. If you live in Franklin County does a great job with all the things that Cleveland's talking about. They have an amazing resource center already up and running, and they've redone the entire jail. The sheriff, Chief Sobart said because of stepping up and what we have shown them, they've designed their jail to really focus on mental health treatment, which just sounds like what Cleveland is doing as well. So thank you all, and we'll give you a few minutes back on your day. Yes.